Hi, everyone, and welcome to the Muslim Sex Podcast. Thank you so much for tuning in. I really appreciate your patronage, and I would love it if you could leave me a 5-star review because that really helps me. And if you could like and share this episode with somebody that you know that may benefit, your friend, your colleague, anyone, I'd really love you to share this podcast, especially if you find value in the Muslim Sex Podcast. Also, I'd love for you to subscribe to my YouTube channel and follow me on all my social media. Also, as you probably know, if you've been listening to this podcast, is that I have a practice that is now open in Chappaqua, New York. I see patients for menopause and sexual health, as well as regular gynecology. So if you are looking for a gynecologist that actually spends time with you, that has time to listen to you, then I would invite you to come and see me in my practice, and I'd be more than happy to take care of you. So make sure if you live in the New York area, or even if you don't, come and see me in my office. I'd love to meet you. And also, last but not least, is that I am hosting again my retreat in Morocco for 2025. So if you are looking for a gift for a family member, a friend, yourself, make sure you take a look at our retreat, the Love and Nourish retreat. It will be held September 19th through the 26th, 2025. Again, this year in Morocco, we will be visiting the same towns. We will be in Marrakesh and Essaouira. And as always, we will be providing information and lectures on menopause, perimenopause, nutrition, and also going for cooking classes as well as excursions. So don't miss out. I know a lot of people were sad when they missed out this past year on the Morocco retreat. So make sure that you go and visit the Love and Nourish retreat hosted by Caria Retreats. And now onto the episode. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about menopause, perimenopause, sexual health, all that great stuff that we always talk about. Before I get into it, the first thing, of course, as you know always, is that this is not meant to be any type of medical advice. If you have any questions, please speak with your healthcare provider. And of course, this is not any type of religious advice. If you have any questions about your religion, please speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super, super excited to have on with me Dr. Noor Al-Humaidhi. And Dr. Humaidhi is coming to us from the Dominican Republic right now. Actually, she's on vacation. So thank you so much for actually coming on during your vacation. I really appreciate it. And for those individuals that may not know you, if you could go ahead and introduce yourself, that'd be great.
Yeah, my name is Dr. Noor Al-Humaidhi. I'm a board-certified family physician. I currently live in New Hampshire, but I grew up in Kuwait. My dad is from Kuwait. My mother is from the U.S. I grew up in Kuwait, lived there till I was 17, and then lived in Europe. I went to medical school in Ireland, and then did my GP training actually in the UK. And we moved here when my mother retired and decided to spend more time here about 8 years ago now. And I got reboarded in family medicine here. And then within the last few years, I've really started to focus on patients with menopause, and not just women, but also men in midlife, and screening and what that looks like, and hormones and prevention. So I founded Lifestyles by Noor, which is my private clinic, and we've been open for about 18 months, and I'm happy to be here.
Thank you so much, Noor, for coming on. I really appreciate it. So, Noor, I would love to know, since you have such a diverse background and not many of us are as fortunate to live in, several different countries, and then you kind of get to know what the country is like, what the environment is like. So I'd love for you to just talk a little bit about, when you were growing up in the Middle East, and then when you came over to Ireland, and kind of, the different cultures that you noted. And then, of course, now that you're here in the US, but I'd love to know about, as you were growing up in the Middle East, what was, sexual health like? What were, topics? Was it a big taboo? And, what did you grow up knowing?
So I would say, growing up in Kuwait, it was a great upbringing. We were very happy. I went to a bilingual school, we called it. So it was technically private. And it ran on the American system from our the English spoken languages, but we had a very cultural, very deeply Kuwaiti cultural influence as well. So, for example, we did religion every single day. We learned the Quran, and I would say, from a sexual health perspective, there was really nothing discussed. It wasn't really on, periods even. I remember, the only reason I knew I was going to get my period was from my friends. It wasn't really something that was discussed, very much taboo. Periods were taboo. Sexual health was taboo. So it was a big gap, I think, of knowledge in my life growing up, which I think would have been useful as after I left Kuwait to maybe just know more. I was very naive leaving Kuwait. I was 17 and I moved to Ireland. I was very naive from a sexual health perspective. And it probably would have been useful to know a little bit more and have a little bit more armor, I think, and preparation, for living by myself at that age.
Yeah, that's amazing. Not many people are living by themselves at the age of 17.
Mm-hmm.
So that is really, really powerful, I think. So as I was doing my research, so I grew up here in Michigan, and now I'm in New York. But when I grew up in a very culturally conservative community. I'm Pakistani, and we didn't talk anything about sex, sexual health, menopause, whatever, any of that stuff. And so I didn't know anything. In fact, I didn't even go to sex ed. I wasn't allowed to go. My parents weren't sure what was going to be taught, and they were newly immigrated here to the US, so they didn't know. So I didn't have anything in terms of like knowledge about this stuff. And so just a few years ago, I kind of went on this path because I was very interested in sexual health as a gynecologist. And I learned that Islam is very sex positive. And I had no idea. That like blew my mind. And I'm curious to know if you ever knew that growing up, or if that something that, perhaps you learned later.
No, I never knew that. It's not something that I would say that I was ever taught or ever heard growing up. It was very much taboo. Nobody talked about sex. And it's funny because nobody really talked about periods either. It was, periods were very taboo. And as you know, in the Muslim faith, if you have your period, you can't pray and you can't fast and you can't, you're sort of very excluded. And I remember it would be Ramadan, and in Kuwait and most of the Middle East during Ramadan, nothing is open, right? There's no restaurants open, and so we couldn't fast, and so you were like hiding and drinking water and hiding and eating. So it was very much kind of like, oh, nobody can know that you have your period. But what your comment about being sex positive, actually, I've never heard that said.
Yeah. Yeah. So it's there. See, you learned something today
Yeah,
too.
I did.
So yeah, Islam is actually very sex positive. It blew my mind when I first read it. I was like, no way. I had no idea. All these years growing up with like just with I don't know, it was like sex negativity, but you just don't know, and you don't know what you don't know. And so there was this author that I read, Habib Akande. He's actually Nigerian. He's a Nigerian author. I've done several podcasts with him. He's fantastic. And I got his book, which was Islam and Eritology, and I was like, what? Like, how do you put those two words together, Islam and Eritology? And then he has another book called Women of Desire, and it talks about how the Prophet, peace be upon him, really encourage these open discussions, and that in Islam, women have sexual rights in Islam. It's actually really important for women to be sexually satisfied, and that women can actually divorce their husbands if they are not sexually satisfied. And all of these things, I had no idea. And then when, in fact, I was talking to a friend of mine whose father is a sheikh, and I said to him, I'm like, did you know all this stuff? He's like, yeah, my dad told me all this before I got married, and told me it was really important for my wife to experience pleasure, blah, blah. And I was like, what the heck? How come I had no idea. I had no idea. And so I was like, all right, this is my mission now. I'm really on this mission to really show people that Islam is very sex positive, that we can have these discussions. And actually in the Southeast Asia, we were very sex positive until we were colonized by the British. And then they brought their puritanical rule, and then, made all of us feel feel like, sex was wrong. There was something wrong with us. And, that was wrong. It was shameful. It was dirty. It was taboo. And then that became ingrained in us. And, that's kind of what we see. And just like what you're saying, right? Nobody talks about periods. It's as if women's bodies are shameful, right? And so we don't talk about any of the things that happen. My cousin is a gynecologist in Pakistan, and I was asking her, what she teaches her patients about like menopause, perimenopause, and all of that. And she said nothing. She said, we teach them nothing. It's just, something that they go through and they don't have medications. I gave one of my cousins estrogen and she's like in her late 40s. She already went through menopause. And I told her, but you can't take this because she still has a uterus. I said, you can't take this unless you can get some progesterone, because at the time I didn't think about bringing progesterone. And she couldn't find it. And she's in a big like metropolis area, a city in Pakistan. And she's like, I can't find this progesterone. I'm just going to give you back this estrogen. And I felt really sad, and I don't think that they have those medications there. And I don't know if you know anything about what they have in the
I,
Middle East or
I
anything like
do. I know a lot because I've been on a bit of a mission because I've had, as my kind of Instagram following has increased, I've had a lot of people in the Middle East, people that I grew up with, and then it's kind of like a spider web out of there. And so I've done a lot of research about what's available in Kuwait because I've had really very desperate women reach out to me saying,
that.
what can I do? And
Yeah.
so the Department of Health in Kuwait will have a list of drugs that they import and that are
Mm,
available, kind of like a formulary. And what's on the formulary is what is available in the country, basically. And there is one HRT formulation. It's an oral. It's called proglutine, and it's basically estradiol valerate and northenderone. And
yeah.
that's the only form of oral HRT available. There's no topical estradiol. There is a form of progesterone that they use in the fertility community, but it's a much higher dose.
Mm,
So micronized progesterone in the forms and doses that we would normally prescribe is not available. Now, I know that in the Emirates, they do have access, and in Kuwait, there's no access to compounding. I know in the Emirates there is access to testosterone and there is some access to compounding. So women there are able, if they see certain providers, generally in the private sector, to get something prescribed, some form of bioidentical HRT prescribed. So I actually have a lot of women in Kuwait travel to Europe and to England, and I've collaborated a little bit with Dr. Louise Newson on this and Newson Health, and kind of tried to help people kind of ferry into her, at least her Stratford upon Avon, which is not too far, clinic to be seen and hopefully get some HRT. And they're able to prescribe a year's supply. So then if they get a year's supply and then follow up periodically by telehealth, and then obviously go back a year later and be seen. And that at the moment is the only way. And I have done some research, and we are kind of working, kind of putting out our feelers to see how we could add more HRT products to the formulary. But it's a question of getting people to prescribe them on the ground. I have a gynecologist. He's a fertility specialist gynecologist in Kuwait, who I went to medical school with. And I mean, when I talked to him about this, he knew nothing on the
yeah.
topic of menopause and how to manage menopause.
Exactly. And I think that, like it is really, really amazing, right? And actually heartbreaking to know that so many countries do not have any access at all. And I think, and when I went to Pakistan last year, I felt like, wow, we really take it for granted here that we have these amazing providers, right? So many people on social media talking about HRT, talking about sexual health, talking about all of this stuff. Whereas, people in different countries have such limited resources. And, we have FDA approved medications. We have, I mean, granted, some insurances don't cover, but I mean, at least there's access, right? At least you can get access. I mean, in fact, I have started up a menopause and sexual health clinic in the Bronx at a hospital that I do locums at. And so we're able to see patients there, and there are providers there that provide menopause care. But it's really sad that there are so many women all throughout the world that have very limited access to not only education but also medication and providers, right? I mean, you can provide, right? If we can get medication over there, that's fantastic. However, if you don't have the providers that have the knowledge,
Right.
like just like what you said, right? And just like my cousin, where they don't know how to prescribe it, they don't know anything about it, then there's no point in having medication there that nobody knows how to prescribe or give out.
Yeah, agree. And when I started this conversation and people started to follow me, it was immediately, oh, hormone therapy causes, cancer. My mother says hormone therapy causes cancer. It's so, again, very similar to, I suppose, the US, but I think maybe they're 10 years behind us in terms of knowledge. But the thing is, they have access, they have access to us, so they can see and they can read and they can see what they need, but they can't get it, which is
Yeah.
exceptionally frustrating.
Right, right. And I would say that, like something as life changing as vaginal estrogen, right? I mean, just think about it. If we can even just, all of the systemic therapy, has so much nuance to it, right? That it's not one size fits all. However, I mean, vaginal estrogen is like safe for, like, I would say like 99% of women, right? And so if we could even just get vaginal estrogen to, these countries and the providers, if we could teach them how to apply even just the vaginal estrogen, it really is life changing. I was talking to my cousin about he introduced me to a friend of his, and he's like part of like the top, whatever, 1% in Pakistan. And so I was talking to this woman and she said, oh, I know that my husband goes off to Dubai, right? And he has another, woman there, whatever. And I don't care because I'm having so much pain with sex and I just don't have any desire and I don't have this and I don't have that. And I don't really care if he's having an affair. And that's what's happening to a lot of relationships is that, as women get older into like perimenopause, menopause, even after they have a child, right? And they can have a lot of pain with sex and without that knowledge that vaginal estrogen can really help them and really change their lives. I mean, not only just for lubrication and arousal, but to decrease that pain with sex, that could really help improve their relationship, even if it was just that they had.
I totally agree. And I think too, it's like anywhere, for it to be addressed, it needs to be seen as a problem. And I think that the link needs to be made between, for example, vaginal estrogen and recurrent UTIs. Like that's where I think that the money is really. I think, you know, people don't want to talk about arousal and pain with sex. I think something like, oh, I have UTIs all the time, therefore I use vaginal estrogen, sounds to them like a much better use, if you like, or need or reason to be using the product. And I think the same for HRT. As you know, in the Middle East, the risk for women, they have a very high risk of osteoporotic fracture, very high risk of metabolic syndrome, type 2 diabetes, cardiovascular disease, really, really, really high rates. If we could kind of draw together the conclusion of the link between hormones and losing our hormones and your risk of cardiovascular disease and your risk of type 2 diabetes, that's, I think, where we can get people really to really talk, you know?
100%, 100%. It sounds like you and I need to go do a world tour and
Yeah.
start
Take it
educating
on tour.
women. Yeah, yeah. And start telling women about all of these, huge benefits in their life and, the longevity and how, and you're absolutely right about the osteoporotic fractures, right? What Dr. Vonda Wright says it's going to be I've heard her say 1 in 2 and then 1 in 3, but really, I mean, very high percentage of women that will experience an osteoporotic fracture and then they won't get better, right? That it's just going to be, for some women, that'll be the end. And
Yeah,
for
I see it
others,
all the time as a family physician. I'm a family physician, hospice physician. I've seen women, go from active, they fall, not just a hip fracture, a compression fracture of the lumbar spine, a humeral fracture. It's devastating. It devastates their lives. They go from, living independently to having this, they can't move, they're in agony, especially a humeral fracture. It's just horrendous because they send them home and then they come and see me for a preoperative visit and you could just see this is the beginning of the end for you. And I can see it. They're going to they're so limited in their mobility after that because of their pain. They end up in rehab. It just kind of snowballs from there. And trying to rescue somebody from that situation is very hard. And when you put an elderly patient into a hospital bed or a rehab bed, I remember I worked with a geriatrician for a long time. This is when I was training in the UK, and he would say for every day that a patient over the age of 65 is in a hospital bed is 4 weeks of recovery to try
wow,
to get back that level. And most people will never get that back. And
all right.
people don't really put those two things together. And I often say to people, just think back, okay, your what 84-year-old, grandmother died in a nursing home. Let's walk that back. And often in the sequence of events, there will have been a fracture.
Yeah. Yeah. No, you're absolutely right. I mean, it's so important to talk to women about how to prevent these, right? And
Mhm.
one of the ways is hormone therapy, but the other way is also to increase resistance training, right? To do these lifting heavy weights. And for a lot of women, they think that if they walk, which walking is fantastic too, but they think that if that's what they're doing, then they're getting enough exercise, and it's really important to
Yeah.
understand that muscle is really the key to longevity, right? I mean, if we work on our muscles, we can help protect our bones, which can really help.
I was going to say, I think there's the barriers to that are, a lot of the women that we're talking to or about now were those sort of, women that were running on the treadmill, or they were doing, the step aerobics and jumping around. And that's what they were taught to believe was exercise, which was
Yeah.
exercise to stay thin, right? That was the whole point of what they were doing. And I remember growing up with my friends in Kuwait, and them being in their 20s and having had a baby, and they were like on a diet. So they would go to the gym while they were on a diet, but it wasn't, I just go to the gym, because that's good for my health. It was, I go to the gym to lose weight, right?
Right.
And to get my pre-baby body back. So we need to help people divorce themselves of this idea that exercise is about weight loss. Exercise is not about weight loss. Exercise is about helping you stay upright for as long as possible in your life. So I think that's a huge key. And then there's this belief that women, we're going to bulk up and we're going to get big if we, lift heavy weights. And that's something that's very hard to convince people otherwise, that, you're not going to get big, you're not going to bulk up. That's not the point of this exercise.
Yeah, I wish, right? I wish I could get some muscle. I mean, like, for God's sake, I'm like trying for, yeah, no, absolutely. It's very hard to, unless you are a bodybuilder, right? That just completely focuses, and that's their main job, is to lift weights and get really big. I mean, it's very unlikely that women are going to get big and bulky
Yeah.
lifting weights, right? It's all about.
So, intimidated. A lot of the weightlifting gyms, are there's a lot of men around. I'm not saying that men are bad, but it's kind of intimidating, and I think perhaps we need a sort of a demographic for a certain demographic of women. I think, a women only heavy weightlifting gym would be really useful, because if you look around, like even where I live in the US, if you look around, all of the kind of exercise places that are really, really kind of geared towards women are things that do, Pure Bar and Body Pump, and, and this with the light weights. And that's not that they're not, that's not great. That's fine. But we need to make safe spaces for women to lift heavy weights, where they feel safe, where they feel like they're comfortable, where they feel like they can be themselves in this environment. We need to create those spaces for women to go to those spaces. Interestingly, though, in the Middle East, they have that, because
Yes.
gyms are generally segregated. So
Yeah.
there are heavy weightlifting only women gyms, which is something I think would be useful to have here. But they do have that. And a lot of my friends, I would say now, within the last, sort of 5 years, have started to kind of really take that on, and seeing the value of weightlifting, and that kind of tide has changed a little bit there. But again, you have to create the space for them to do that safely.
Yeah, yeah, absolutely. And that's fantastic actually, that a lot of your friends are lifting heavy weights and things like that. I think that that is, at least for me, that's a new concept, right? That's something that I'm learning. And thanks to all of these people that you and I both know, and speaking very loudly about lifting heavy weights, and, not just relying on 5 pound weights, whereas, there's really nothing wrong with 5 pound weights. I mean, I lift 5 pound weights, but anyways, right. I mean, lifting heavy is really, really very important. I'd love to know what you think about, where we're headed here in terms of education and getting the word out about hormones and longevity and muscle and all of that.
So I think, for example, social media is a bit of a wild west right now in terms of information. I think women are confused. I think it's an overload of information. So I think a lot of women just turn it off, because it's like, that's too much information. And it kind of puts the onus on them figure it out or to somehow discern what's true and what's not true and what's accurate and what's not accurate. I'm sure you have it like in my DMs every day. It's like, well, my doctor did this and my doctor, of course I can't respond to that, but you can see the difference in how people are practicing what people are doing based on women that reach out to you on Instagram,
Right.
or by email. Even they email our kind of info at lifestylesbynoor email. So I think it's women are in a really difficult place. I think they the information is out there, but it's who they have a who do I believe sort of, because a lot of the information is contradictory now. There's people contradicting each other. There's people contradicting on screening. There's people contradicting each other on what's the most appropriate use of HRT. A perfect example is perimenopause. Like there's this whole furore in my comments about progesterone use in perimenopause, about, cycling and not cycling, or do you need progesterone? And then, my comments are full of women saying, I'm in perimenopause and my doctor only gave me estradiol. And you're like, well, okay, I can see where they're going with that. It's really hard. And I think women are caught in the middle of this very, very contradictory landscape.
We were talking about a little bit before is that it is, nuanced, but I agree with you. I think that it's hard for women to figure out what to believe, not to believe. Sometimes it's just overwhelming and sometimes you just don't want to even get started, right? But there are women that are absolutely suffering. And I think that when we see that the women are suffering with hot flashes or night sweats or, joint pain, and they're, in their mid 40s, late 40s, then I think it's really important for them to go see a provider so that they can get some help, because I think that that really absolutely impacts their life, and we know that women that are in perimenopause and specifically menopause, we know that they will forego when they are promoted, they'll forego promotions. If they feel like they can't function due to brain fog, or if they, we saw that article in The Guardian about women that were experiencing the gender urinary syndrome of menopause. And that one woman that had quit 4 jobs because she was just so irritated and uncomfortable and she didn't know what to do and she didn't know who to ask. And then finally she got it resolved. But, it's unfortunate that a lot of practitioners don't have the information that they can then help their patients.
100%. I mean, I've had patients that have had genital urinary syndrome of menopause for 30 years and nobody's done anything about it.
Wow.
It's,
Yeah,
they've canceled vacations. They haven't gone places. They quit their job. They're, haven't gone to see their grandchildren, haven't gone to their children's wedding. I mean, that bad that they're carrying around, you know, backpack full of pads and sanitary things because they have such terrible symptoms. And
yes.
then you give them vaginal estradiol and it's over within 3 weeks. And
Yeah,
the anger that you feel from these patients, of course they're angry. They didn't have, access to this simple intervention. But you're right, women are suffering. And I really think in perimenopause, from my experience, I think the mental health aspect is the most is really for most women the most debilitating, especially in perimenopause. And I think a lot of women in their early 40s are struggling. Late
mm,
30s, early 40s are struggling. They don't realize that it's their hormones. They think it's their life. It's the stress of
yes,
their life, their job, their children. They will convince themselves it's anything other than their hormones. And that,
right,
and they're suffering. And these women, their relationships are ending. It's horrendous. They have, they can't sleep. They have suicidal ideation. Some of them commit suicide. It's just shocking. And the potential
yeah.
benefit of just this most simple, just a little patch, and a capsule can literally turn around not just their lives, but their families' lives.
Absolutely. Absolutely. Yes. And so I've had a few patients in the clinic that I go to once a week in the Bronx. And, women have not only just in the Bronx, but like really everywhere, right? Where they haven't been heard, where they've been dismissed, where people are not listening to them. They suffer for a very, very long time until they finally find a practitioner that, just like you said, gives them the hormones that they need. And then their life changes, their relationship changes, they become better, they're happier, their spouses are happier, their children are happier, right? It impacts not only them, but their whole family. And so it's so important that we really address these things. And I feel that, women, it's they've been dismissed for so long. But honestly, I'll have to say that in my training, at least here, Noor, we didn't get much. I mean, after 2002, we didn't learn much about perimenopause. We didn't learn anything about menopause. And I was in residency at that time. And soon as that, WHI study came out in 2002, we were told, like, hormones are bad. We don't prescribe it. They give a breast cancer. And that was it. I mean, like, we didn't learn anything, nothing. And so even up until, like, I would say 2021, I was part of this academic facility, and they were not teaching their students. And I can tell you that because I was one of their, one of the lecturers for their, and we would talk about like miscarriage and this and that, blah, blah, but we were not talking about menopause at that time. And this is 2021. And I know that they weren't getting it in their residency about menopause, perimenopause, sexual health. They were getting nothing. And so I think that now, slowly things are changing, and only few residency programs here in the US even talk about those things. And I think that, we are still really, really far behind. And I would say that, patients don't know what's going on, but clinicians don't know what's going on, right? So they're ordering this huge workup on these patients, and they don't realize that it's a whole constellation of symptoms that, comes from being perimenopausal.
Exactly. I mean, it's like it's only obvious if you know, right?
Yes.
So
Yes.
if it's not at the tip of your tongue and at the forefront of your mind, you're not going to think of it. But if
Correct.
it is, you're going to immediately think of it, right?
Right.
It's
Right.
and if people don't know and you don't tell them that this is potentially how this could present, they're not going to know. They're going to go based on how they're trained. I mean, I was trained in the UK, right? And I remember I remember being in a GP practice, during my residency, and it was like, how long has she been on vaginal estradiol? Oh no, you need to cycle it, and they would be like, you have it 3 months on and 3 months off. Honestly, honestly, that was, and to think, I mean, we were stopping people's vaginal estradiol. It's just, oh God, it makes me want to die.
Yeah. Yeah. But
But I mean, we didn't know. I mean,
yeah.
you don't know what you don't know.
Exactly. Exactly. And I think that, now with so much information everywhere, I think it's fantastic. And I think
Mm-hmm.
that, thankfully, at least here in the US, women are able to hopefully find providers that they can go to, that they can get some help. But, as we both talked about earlier, that, people in different parts of the country really they struggle with this, and I wish that we could change it for everyone. I think it's really important. Are you fluent in Arabic? I mean, could you create a course in Arabic? We could use AI. Actually, we could use AI to create
I'm
that course.
not fluent in Arabic anymore. I mean, it's funny, when I go to Kuwait, after a couple of days, it's like it's back, but it's not something that I'm using every day. So it's not
Yeah,
something that I could immediately call up, but I can read and write.
it's amazing.
Yeah.
Yeah,
I was
it's
going to
fun.
tell you, this just to kind of pull at the thread of families. I think that people don't realize that we always talk about women and their suffering, which is really important. But I think if spouses and partners realized,
Yeah,
and the effect it's having on their kids, and
yeah,
if people like, I'll give you a perfect anecdote in my home. So when I went through perimenopause, it was awful before treatment. And one of the big ones is I couldn't sleep. I was like a crazy person in the middle of the night. I would hear things. I would be up roaming around looking for the things that I had heard. I mean, it was not good. So a few months ago, my daughter we were sitting having coffee in the morning, and my daughter came down and she's like, she didn't sleep well. I said, oh, what's wrong? And she said, well, I woke up and I was thirsty. So I wanted to come down and get a drink of water, but I said, why didn't you come down and get a drink of water? And she said, well, I didn't want to, you wake up and I didn't want to wake you up. And I thought, and then my son, and I thought, that's heartbreaking. And then my son, who's 15, he pitches up and he was like, oh no, mom's on her hormones now. She could sleep. So they
Exactly.
know just from their own experience of their mother, the huge impact this has had on my life,
Yeah,
you know?
yeah, no, that's fantastic. Yeah, he's right. You're probably much happier now too,
Mm-hmm.
right?
Yeah, exactly. Their mom sleeps. So when she wakes up in the morning, she's present and she's not irritated. She can have a conversation with you. She's not immediately angry, which is a lot of women in perimenopause say, I'm just like yelling at my kids. I don't want to be this person.
Yeah,
And you don't
yeah.
have to be. That's not you. That's your hormones, and we can help you.
Yeah, 100%. And in fact, I just had that with a patient actually last week. She came in, she's on a very low dose estrogen. I think she needs to actually be up a little bit higher. But she told me, she's like, I'm under so much stress right now, and I'm yelling at, everyone, yelling at my kids, yelling at my husband, blah, blah, blah. She's like, that's just not me, and I don't know why that's happening. And so we actually checked her hormones, and her estrogen is really low. So going to increase it. But you're absolutely right, right? Like, women will know that this is not them, and that perhaps they they need to be on some hormones or maybe even a higher dose because, things are not the way that they used to be. And this is not them. I'd love to know what it is that you see mostly in your clinic. Is it, do you see perimenopause, menopause? Is that kind of your focus, or you see everyone?
So I see midlife. I would say I see midlife women, and we're just starting to see midlife men as well because I've had so many people ask me about their husbands and partners, and I'm a family physician, so I treat men all the time anyway. So I have in my career, but we see mostly. I would say that I see mostly women between the ages of about 30 and 75, something like that. I do have a couple of younger women with PCOS and that sort of thing, that have just been offered the pill everywhere else and they want to try other options. So I do see younger women, but I say my door is open to anybody that wants to have a conversation, but that's kind of the demographic that I see.
Okay. It's fantastic.
Mm-hmm.
So, if you were to give three pearls to somebody listening here on this podcast and wondering, like, they talked about such great information, what are three takeaways that you think somebody should walk away listening?
The first one is that everything needs to be individualized and there's no size fits all, no one size fits all. And going on hormone therapy requires a partnership with your prescriber, your provider to find what's perfect for you. I have a lot of people that they start it doesn't work, or they get side effect or something happens and they just ditch it, right? And so I see a lot of those people that have done it somewhere else and then they come in and they want to, have another conversation because they had a bad experience the first time. So I would say that would be my first pearl, that you have to partner with your provider and have trust to find the right and perfect, dose and make sure that it's nuanced for your needs. The second pearl, I think, would be to say that whatever contraindication you think you have is unlikely to be a contraindication to HRT. There's a lot of myths out there about, oh, I have migraines, or I have cardiovascular disease, or I have diabetes, or I've something has happened in my past, or I have a family history of breast cancer. I have a personal history of breast cancer, and that's immediate no. I want everybody to know that it's never an immediate no. It's always a conversation. And I think the third pearl is you're an adult and you can make your own decisions. And if you decide that this is the best thing for you, that's perfectly reason enough to start hormone therapy.
Yeah, those are fantastic pearls. I think you're absolutely right, right? Like it's really an in-depth conversation. It's looking at the risks, the benefits, what are you trying to get? What are your goals by taking this? And I think that it's really an important conversation and it does take a little bit of time, right? And it's important to see the right providers so that they can provide you with that information. So I think it's fantastic.
And I think sorry, I'm just going to interject. I
Yeah,
think there's a
yeah.
place for everybody in this conversation. People talk about me, doing private work and, running the model that I run versus, a primary care provider versus, your gynecologist. That's, everybody has their place in this conversation. It's not I'm better than that person or that person's better than me. It depends on what your needs are. And so I think if we can educate everybody, there's plenty of people out there that are, their HRT dosing is very simple. They respond beautifully. It's easy. It's all easy. And they're the perfect person that can see their primary care and see them once a year and follow up with them. And then there's people that it's not. It's a little bit more of a nuanced conversation and they have family history or whatever they have, and you need to have a little bit more input. And that's perfect for me to come and see me because I'm willing to have that longer conversation. It's a long-winded conversation. It's a lot more involved. And that's okay too. But I think that there is somebody for everybody.
Yeah, I think you're absolutely right. And I think that's fantastic that, people should have options, right? And if they don't find a provider that, will listen to them or somebody that resonates with them, then there's definitely lots of providers out there. You just have to go to the Menopause Society .org or menopause.org, and they do have a list of providers that are Menopause Society certified practitioners that you can go and find and hopefully find somebody that, will listen to you and, give you what you need, which I think is really important. I think something else that came up in our conversation, which is really important, is that you and I have a lot of work to do. We should get together and try to go to different countries and educate physicians and also try to see how we can get medications over there because I think that's really important, right? I mean, I think it's fantastic that we have access here and we have providers here, but I'd love to spread that knowledge and education to people all over the world. My podcast is actually global, and the country that downloads it the most, before it was Saudi Arabia, now it's actually India. And I have the most downloads in India. And, people are really hungry for this information. People all over the world are really, really looking and seeking information on their health. And so I think that's why it's really important that there are people like you talking and on social media. And I think that's fantastic. So thank you for all that you do. And so for somebody listening out there that thinks that you are just fantastic, they just really enjoyed everything that you talked about, how can they work with you? How can they get in touch?
So I would go to my website and you can, I'm very happy to do a 1 hour consultation with anybody that wants to just have a conversation. I am currently licensed in Maine and New Hampshire. We're working on a couple of other states right now. But if you want to have a conversation and bounce things off me, and that's perfectly fine. So I do see people from abroad, and we have a 1 hour consultation. We go through their history and what they've tried before, what they have, and I give them kind of a bullet point kind of plan, that they could perhaps work with their prescribing provider to discuss, potentially labs to order, medication to try and things like that.
All right, amazing. Well, this has been such a great conversation. Thank
Thank
you
you for
so much,
having me.
Noor. Thank you so much for coming on. I really appreciate your time, and especially because you are on vacation. So thank you for taking the time out
Anytime.
on your vacation. So,
Absolutely.
well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. If you have any questions about your health, please speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.